and then I'll pass it off to you.
All right. And then I'll probably just share my screen. Well, I'll talk a little bit and then I'll share. Okay, now I'm the host. And then I'll go back. Let's see, where's my tool? Is it to me? How do I do it? How do I get it back to you? I'll figure that out later. So anyway, so my name is Johan Gamelius. I've used to work for IGenix and then jumped ship there this spring to what was InfectoLab and now is being rebranded ILabs. People were not liking the Infecto in the name as much and figured ILabs would be a little more palatable because we don't want to infect people. We want to find out what infection they have. So, so that's kind of the story behind that. And we're also branching out a little bit, changing slightly. We actually had a lab from Poland came in and became our majority owner. They're called ILab if you ever look it up on LinkedIn and anywhere else, and they're second or first biggest lab in Poland. And they wanted to get a foothold in the US, and they looked at InfectoLab and thought that was a good market to get into and their product mix, and they could add some stuff. So long term, we'll add new testing as well. We're looking at some mold stuff potentially, things that go hand in hand with not only Lyme and tick-borne diseases, but also like long-haul COVID and all these things that are hard to diagnose. That's kind of the diseases that fall into the integrated and functional doctors. So, yeah, quick little background. So I worked for IGenix for almost 8 years. And I think I've had plenty of, I think I had one live meeting with you guys. I would bring in Bob Jagir, 2 meetings, with me and do them in the early days, so to say. And then I think we've had two probably with IGenix for the Zooms, and now with InfectoLab. So, but I like to keep things really informal. So if you have any questions, raise your hand, and I'll try to have so I can see. Let me see where I'll put that, but the chat function. If anyone has anything, or wave your hand and I'll look at you, and we'll open it up for people. So, yeah. So why InfectoLab? So I'll share my screen, and I have a brief introduction that actually Felix Schultz, our CEO, who is our PhD and head science guy, and I think a few of you had visited the InfectoLab office as well. And I like to be more common in my approach, I should say, not maybe so try to be as scientifically accurate as possible, but also put in layman's terms so we all can understand better, more than Felix. Felix has a hard time. Certain things you can't simplify. And I'm like, well, you can simplify it so we can all kind of learn from it. But so I'll try to do that through my presentation, and you can stop me at any time with that. I was going to bring you. Let me see here. Share. Where's my? Here we go. So I can share my screen. There we go. Entire screen. Share. All right. There we go. So now I'll just have to move some of the stuff out of the way. Yeah. Oh, and I'll click on that. So here is our new rebrand. So we're going to be ILabs or i-labs.us. We can see the lab up here. We're just building this. It went live. There is not that much stuff in there, but it talks about our testing like anyone does. Our focus has been T-cell testing, and which is different from IGenix where I was before, and I still love IGenix. There was no issues that way I was leaving. I just thought it was a new challenge with these guys, and they have some really cool tools with their testing that they can kind of see where the progression of the disease is and how well is treatment working. And I hear that from a lot of providers that they're interested in it. So I kind of, when I had this opportunity, when they're expanding, I jumped at it. So, and it doesn't hurt that it's 15 minutes from my house, so I can go to the office whenever I want to. So, any questions? I'll have to see here if I see anyone. Any questions so far? Doesn't look like it. All right, Perfect. I'll continue. So, I mean, we have patients talk about our testing options. We will have, this is where I think will be most interesting. We will have some educational videos coming up, but we still have some available on InfectoLab.us or Americas.com. But we will move those over and change the labeling on or the labels on it and the lab. And the same thing here. We will also then, part of what we want to do is we want to have some webinars with providers that we then will be able to have on our web page, so we can show other providers what we do and what we want to do with our testing. So kind of to educate them as well. All right. Now I think I need to go to. There we go. Oh no, I gotta go to my. There it is. All right. So here is, can everyone see my presentation? I hope so. Okay. So I'm just going to walk through this PowerPoint presentation, kind of talking about our testing. So basically, our foundation of our testing is T-cell testing. It is, as I see it, the most closest to a direct testing you will have versus an indirect testing. So quickly go through that. Direct testing are something that would detect the actual pathogen right now, which would be, or in recently enough, which would be PCR testing, FISH testing that looks for RNA, things like that. Then we also have the indirect that look at the response of the immune system. So that would be B-cell testing, like the immunoblots that IGeneX are running, etc. And then also the T cells. So why T cells are really interesting. Let me see here. There we go. The immune system have two major branches. Where did my little sheet go here? The innate and the adaptive. So the innate, and I'm going to go through this pretty fast. The innate is more the first response and the physical barriers, etc., to keep a pathogen from entering the body. It also has some cellular components like natural killer cells and things like that. But basically, it's like the first response. And then the adaptive immune system is antigen specific, and it learns from what attacks the body. And the main cell types of that is the T cells and B cells. We also have other ones, but to simplify it, that's what we're going to look at right now. So here we go. And the T cells are very crucial. They're the first response in the body. So, we have a pathogen coming in, and I will show this a little bit later, where we have the naive T cells that are kind of roaming around in the lymph system, and then they get triggered, and then they pass it on to and train other T cells to look for this thing that's trying to invade the body. Some of the ones to look at, the distinct roles, are the helper cells, the CD4s, and the cytotoxic T cells, the CD8s, and we can measure these. So that's kind of what we're going to use in our testing later on. See, all right. They're very antigen specific, which for us is good, because as long as we have a good antigen that can detect the specific pathogens we are looking for, we can then, in a ELISpot, is the system is called, which basically is a immunoassay that we then can see if the antigen is triggering anything in the blood, and then we can count that response. But to get there, we first have to have enough of these T cells. So they're basically circling the body, as we call them, CD4s and CD8s and naive T cells. And they encounter something, and then they start multiplying. Here we show a little bit, skin wound, something is coming in. And here we have the little cells gobbling it up to see what it is, see if they already know what it is, or if they've encountered it before, if it's a new thing. And then if they say, oh, this could be trouble, then they spring into action. And that's kind of what we see here in the lymph node. And they will either become a Th1 interferon gamma or a central memory T cell with is interleukin 2. And we can kind of see here how they split in. So basically, the first one to get activated is the Th1. And then after that, we get more and more of central memory cells so the body can remember if it ever encountered this pathogen and start fighting it. All right, so any questions? Nope. You can text me too if you need anything. I'll keep going. So the burden and differentiation. So here we see in the beginning, we see mostly, well, depending on how they differentiate, you see the interleukin 2s and then also a cross section of them, and you also have the Th1s. And here we go back to the burden where you are in the exposure. So first, really not a lot happens. And if, say, it's infecting the body, then the T cells, Th1 cells would see it and they will spring into action. And it will take a little bit of time because they have to multiply. But this is like a day, like right around when you get the infection starting. And then the response is triggering faster, and you are still, and then hopefully you get some treatment or you're feeling better, the body can fight it off, and then you get less and less symptoms, and then you get down in number 3 here, which is more of the recovery. And we'll show kind of what's interesting is with our testing, because we look at both the Th1s and the interleukin 2s, you can see how it changes through the infection and how you can see it clearing after treatment is working better. And we do have these, we'll look at more what type of test we have and what we look for. We're not as comprehensive as IGeneX is, so that's kind of the drawback. And we're not as specific like they are with some of their immunoblots. That's where I look at this more of not like necessarily a straight alternative, but it's more as a supplement to see how you are doing and how progression is going after you are receiving treatment. And here we also can see a little bit more that we comparing the different T cells and B cells as well. And actually we have the A's, IgAs in there as well. So first thing we see RNA, basically, yeah, you can detect that as 2, but then you have the T cells coming in through the active infection. We see recovery. They're going down a little bit, but they still stay here, which is the kind of the interesting part. And go to the next one. All right, so what we can see in our ELISpot, we actually, this kind of looks like what it is. We have a little file that we do the testing in, and in the beginning, we see mostly Th1s, and each one of these is activated cell. So we count these. This is what you see in the test results. So in the beginning, you really only see Th1s. Then we get into kind of the middle of it, or after the initial peak, you will see Th1 cells and central memory cells, a little bit both of them. And then when you get further just into the clearance, the body will keep the central memory cells longer to be able to recognize this infection or pathogen later down if it's getting attacked with it again. So then basically Th1s disappear and it moves all into central memory cells. We see more and more of this with, say, like Lyme and stuff, where you will probably keep a little bit of a load in the test results. The central memory cells will still be activated, and you will also, not with Lyme necessarily, but you should see a clearance of these after you test, and you have had treatment. You're feeling better. We can look and see, okay, we get rid of this disease. We might have to look at if you have something else that we are dealing with as well. And I was going to say what we try to do with, we look at both the T cells, but then we also now pair it with an immune assessment to see how hard your immune system is working and how effective basically it's working. And that's where we can see if people are dealing with immune exhaustion, etc. And that's kind of where I like it. It's a really interesting side of it and be able to have that testing to kind of get more of a proof as, yeah, I'm feeling good. Am I really feeling good? Or I'm feeling really bad. What am I dealing one of these diseases that have reactivated, or what could it be? And by testing one of our panels, you get more clarity in that. It doesn't have all the answers, but they have quite a few. And I think that's where our long haul COVID test can help a lot of people, because there are a few other ones in the marketplace, but we are actually looking at the the T cells to see if they have been activated recently. All right, so now I'm going to go in a little bit. Let me see here now. Maybe I should unmute everyone. Let's see. Does anyone? Let me see here. How do I do? Here we go.
We can each unmute ourselves
Oh,
too.
you can. Okay, good. Yeah. So if anyone have any questions at this point, please unmute yourself, and I can want to cover kind of the first part just with the main T cell testing before I get into our CD8s and CD4 testing. So anything at this point? All right, I will continue. So for our immune assessment testing, we have a couple of different sides. We actually look at immune assessment and then also at exhaustion. So the CD4s will orchestrate the local in the tissue, so we can see the intensity of how hard these are fighting and how many of them are fighting, and that's going to be the interesting part later on. And this actually talks a little bit about our PD-1 exhaustion test, and we have well, this is the CDL. It kind of goes in a little bit with tumor testing and how the body is fighting its own system against specifically cancer. All right, so here we go down to this is the one I really was looking at. So by being able to we stimulate the CD4s and CD8s, and then we can see how hard they're working. And this is the unstimulated. So, and then when we stimulate it, we can then, there goes stronger response and harder response this way. And then we can quantify this and give an average, so we know the percentage of active CD4s and CD8s, and the AIA is how many of these cells are working as we stimulate them. All right. Oh.
I have a question.
Yes, go ahead.
Okay, while we're on the CD4 and the CD8,
Yes.
what aren't those the two that like the doctor is running to see where your range is, to see if you're getting better or you're getting worse with Lyme, or I guess cancer too?
Well, sort of. You can't really see it, but you can see how hard your immune system is working. That's more or less what it is. You can't look at the CD4s and CD8s, especially is not. I don't think that would say like the clearance necessarily. It's more like how hard they're working, and if it's a relaxed immune system, or if it's a really hyperactive immune system. And after a while, after it's hyperactive, they can only stay hyperactive so long, and then you would see less and less of fighters coming out. And so, I wouldn't, at least in our testing, we can't say with the CD8 and CD4 specifically for that disease, but we can see overall how hard they're working. Does that make sense?
So if you say you've been ill with Lyme for a
Mhm.
long, long time,
Mhm.
and then you have these tests and your immune system is just exhausted, wouldn't that make the test look maybe not realistic? Because
No, no, I mean,
you
you
don't know
can
how
get,
long you've had it.
it depends. I mean, and it depends how your immune system is fluctuating too. Yes. Um, but necessarily it also will see if, I mean, you must have, I mean, I shouldn't say, you have times where you feel worse and when you feel better. By seeing is that immune system then recuperating when you're feeling better, or if it's still the same stress level. I guess that would be some good information for your doctor to have, right? Does that make kind of sense what you're talking about?
Well, yeah, but also in the treatment, say if you're under treatment,
Mm-hmm.
say with chemotherapy, or you're under treatment for say an IV for Lyme,
Yes. Mm-hmm.
how would you know if your immune system is responding? Wouldn't you do it with a CD4 and a CD8
Yeah,
test?
you would. Yeah, you would. That's where I'll walk you through some of the stuff and maybe we'll get some more clarity. And our exhaustion test, we actually looked at, it's a um, PD1 test. And that kind of is more specific for cancer and things like that. And we'll walk through that a little bit later, but that's another interesting test where we can kind of see more what's going on. And if it's exhausted, then we might have to say if you're on chemo, one of these targeted PD1 therapies for cancer, then maybe it's time to lay off of it because it's not effective at this point, and then wait till your body can help and better fight the cancer at that point, instead of spending money on an expensive drug that's not working currently, right? And then
Right.
take a break, it's kind of cycling it back. So that's where we think, and we're actually working on some really exciting studies on that to see how our specific PD1 test, exhaustion test, how we can um, help the provider then pinpoint what treatment to have at what time. So we'll have more coming out with that. But yeah, it is, the only problem I see is it's not specific for one disease, right? So we don't know necessarily unless we test for it with our T cell, which disease it could be, right? So that's kind of one
So
of the drawbacks with it.
if there's another disease, because you've got some chronic
Yep.
things going on, if there's
Yep. Or
other,
mold could be
right,
one thing
right,
too, you know.
right. So how can you tell which one's
I
working?
can't really tell, but that also tells you then you have to keep looking, right?
Yeah,
So I mean, if you have one, you can treat, say you have Lyme, you can work on the Lyme or Babesia or Bartonella, and we can see what stage that is in. And hopefully you get result where we can get down that to a level, then are there other diseases that we are not looking for that we need to also target? So this can help the provider and you kind of put that roadmap together. Oh, I got it. My dog decided to come in and visit, so I was wondering what that was. Sorry. But I'll hopefully that will make sense as I go a little bit further, and we can talk about that. So here I like to look at um, when all the results are negative and it's nothing is really, the body isn't fighting infection, just to get the baseline, and then we can look at some other examples of people that have been tested. And these are all fictitious, or names have of course been moved, but so here is a patient that we have looked at Borrelia burgdorferi, the B31 and the OSP. Hold on, no, Brookie, you gotta go away. I don't have time. No. Oh, there. Sorry about that. So here basically, so here all negative. So you would see basically the result is point 25. So that's less than 2, it's negative. We also look at the borderline, and over 4 is positive. And we'll have some other ones that are very positive. So doesn't seem like any of these diseases or pathogens are what we should worry about. Then we look at the activity, CD4 activity, which is percentage, and it's at 5%, pretty calm. Then we also then look at the individual ones, the amount of cells that are fighting or activated, and that's pretty low on this whole scale. The CD4s or CD8s, the same thing, percentage, about 10%. It's a little elevated, but not much. And the amount of cells are also consistent. So this is pretty calm. Then we will look at another patient, CMA reactivation, CMV, sorry. And 295 is very high, right? So we know this is very positive. It's an active infection at this point. And then we look at the CD4s, the percentage. No, sorry, this is mixed. Every time this is weird. So the percentage of them is 21, pretty high. And we have like 10,000 of the individual cells working. So we know that immune system is working hard. Same thing here. Percentage is 32 of the CD8s and the individual ones. So later on, we'll look at this. We'll see the percentages go up, and then, or percentages being up, and then the amount of fighters are pretty low. Then we know the immune system is more exhausted at that point. All right. So an autoimmune patient, active CD4 cells. So we also have looking at the killer cells here. We have a bunch of interleukin stuff going on. So here we can see the percentage very high, well, about 16% or so, but very low on the individual cells, that we know that it is a sign that it is more exhausted, that it's been fighting this thing for a long time. And I think we see that in autoimmune patients more commonly. And then we have to, then as a provider, since I'm not a provider and I can't give advice that way, we have to find a different way of either fighting this, or if it's early, maybe, I don't know what kind of treatment they actually would do in this case, but it is good for them to know that. All right, so here's one that I like too, which is the Epstein-Barr reactivation. And interesting part of this one is it's basically the Th1s that are positive, and we are negative at the interleukin. So this would tell me it's more early in the infection stage, right? And on this one, we are looking at the percentages, 8.5. So it's still fighting pretty good there, but it's a little lower on the percentage of this one and high. So it looks like in the beginning of the activation, we probably get some treatment, and hopefully the immune system then should be able to raise itself and fight it a little bit harder too. All right. So now, does that make sense from what questions we had a little bit earlier, or did it just confuse you?
Well, you just mentioned that the Epstein-Barr, you need to fight it a little harder. Okay, what are you fighting it with? I mean, how are you linking this with?
Well, it depends what kind of treatment they would. I would say the body would, since it's early in the well, at least the Th1 indicates that we don't have a lot of central memory cells at this point. So that would indicate that it's earlier in the exposure to it. I mean, it could be yeah, so I mean, we at least caught it early and we're aware of it, so the patient shouldn't worry about any other diseases at this point. That could be the EBV, and I don't know what treatment they would have for you to be able to for Epstein-Barr, but at least we know it's early.
This test doesn't show anything as far as that it's a virus that was already there, activated, you have to ask the patient, I guess.
Yes, absolutely.
Uh,
Yes. And you would know the history of that too. I mean, I guess we can't say it's reactivation because we don't know.
So you can't tell if it's an old
No,
virus.
no,
It's
no, you
like,
can't.
okay.
You can't.
Mm.
Unless you have a history of it, or we know, say, COVID, you've had COVID, and then it could come back like any of the other diseases that like to tag team with COVID. But usually the provider would know. It would be history that the patient have had, right, with EBV in the past. But once again, we would. That's where I would be able to have, if we have a provider on, they could speak specifically to those things, and that's not my expertise at this point. So, all right. So this is really the exhaustion test that we have, and the PD-1 is one way of looking at the exhaustion level, or we can measure that side of it at least. And that's where I was talking about. We have some specific trials that or not, I shouldn't say trials, but what's the word I'm looking at? Studies that we are trying to do to show more how useful it could be for specific cancers. So basically, but it works, so we can measure this similar to what we looked at for the CD4s and CD8. And why this kind of, talks will, I will show this here, and that kind of makes a little bit more sense. So we look at certain expressions that we can measure, and then we can come to the conclusion how hard the PD-1 level is working. So basically, hopefully this will make more sense, right? So we have the receptor of the active T cell, and they can bind with certain proteins and respond and attacking them to kind of have the body's immune system fight the cancer itself. And that's where we have some of the newer oncology drugs that would actually help with that, to work on specific T cells. Now, so the T cells detect unfamiliar abnormal proteins on the surface and then respond by recruiting other parts of the immune system to destroy the cell. Now, some cancers are smart and they want to evade the immune system, and so they're cloaking themselves in the proteins called PD-1, PDL1, and PDL2, and they bind them to the receptors, so then it suppresses the ability to get the body to fight this disease. And I think I have next one will explain a little bit more. So here we go. So immune therapy drugs are designed to block the binding of the PD-1 receptors to the PDL1 and PD-2 of the cancer, right? So basically, allow the T cell to see through the cancer cells, or try to fight it off. So, but after a while, this seems to be only effective for a certain while, and our testing then can detect this. So here is kind of what it looks like. We're still looking at the CD4s and CD8s and how much and we can measure how much of the PD-1 they express. Kind of the same as we do with the immune system test that we talked about before. So stimulated, unstimulated, and Okay, Brooke, nope. And we can say how high is it working. So let's look at some results. This is for COVID. And we see very low activity percentage-wise. And then, so this is same as we were looking at before. And then the amount of cells working, not very high. And the same thing with the CD8s, percentage low and low. And then we move over to look at the combined one on this side. And, oh, I gotta move this one now because I can't see. I'll move that one to the side here. And basically, oh, Brookie. So first of all, yes, SARS-CoV is negative and it's not working very hard at any of the side of it. And the percentage, we are looking at the CD4 PD1, low, 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 low. And then the combination one is PD1, PDAI. So this is the bigger one, but it all looks kind of calm. So look at one other one. This would be a mold one. And we see very active, well, 5.7, so positive, and kind of in the middle. And on this one, we see high percentage working, very low percent or low amount of the cells are working. Percentage-wise, high and then low. And then we see the same thing here. Kind of working a little bit harder on that one. And then the percentage here, mid and a lot. And then the combination of them, we're seeing it's working very hard. So that could be potentially. And then we're looking at another one with Epstein-Barr, like we talked about before. And we see very low, like we talked about before, not many, all the way through. And then we get to the combined one that is super high off the chart, which tells us that it's probably the PD1 is exhausted. And we can walk through a couple more of these ones, but I don't know if that really makes that much more sense on that side of it. But I want to at least talk about some of the testing. Let me see where it's going. Some of the testing opportunities that we have to gain more insight in what could be going on. Any specific questions at this point?
So every test that you went through here, they are separate patients. It's not a
Yes.
patient you're testing.
No. These are just examples. It's not the same patient at all. No. So just to illustrate what it would look like on the test sheets that or the test results that come out.
So if the doctor doesn't run more than just one or two tests, that possibly they're going to miss what's going on in the immune system, the big picture. Is that correct?
Sometimes, I mean, it depends. I think more or less it's a different test to see what is happening in case that, I mean, hopefully you would have, let's find one. Well, we don't have to go through that, but hopefully you would have, let me see if I can put something else up here, but hopefully you would have a test where it is positive so you know what to treat. Now, if you don't have that, then we have to start looking for other things, right? And that's kind of where it would give, say you've been treating one of these diseases and then you're doing better and it doesn't show up, then we have to look for other diseases to go after, right? So it would give the doctor at least a indication where your immune system is and what else we would have to look for if it's not one of the tests that we are doing. But of course, yes, the more of these things you know and you can test for, the better it would be and most likely to find something that you are fighting, right? All right. So that's pretty much all I have to walk through. The things that we have currently. And I'm also actually what I was going to do is I was going to go through. So we have redesigned all our little stuff. So currently, these are the tests, individual tests that we can run. So Babesia, both Duncani, Macrati, Bartonella, Henselae, and Borrelia, we are looking at the Burgdorferi, Efzeli, and Garnini. So basically the B31 and one other one. We are doing Borrelia miyamotoi for the tick-borne relapsing fever. And then we have a few other ones of these. I do like the COVID one. Actually, we have a COVID panel that I think people can gain some more insight what is going on if you're dealing with problems like that. For you guys, I mean, definitely it's the tick-borne ones that otherwise you wouldn't be at in the Lyme Association. So, and we're looking to increase some of these as well and finding other testing that would fit into what we're doing. One of the things we're looking at are what other mold testing, et cetera, we can do. Because we seem to be, that seemed to be something that's very concerning to most of the tick-borne disease patients that we deal with.
Is the HHV6, is that, do you break it down whether it's type A or B, or is that just general?
That's just general, the HHV6, yeah. It's not, we don't break that one down. I mean, so we're kind of limited to what kind of antigens we can have, and we want to make sure that they're, extremely specific for what it is. And that's why for like some of the, we don't have as many strains as say IGeneX have for their B cell testing. But I do, the B31 might cross over to a bunch of other ones as well, but we don't know that for 100 for sure, right? So we try to be as specific on these and look for them where we can, so we can add more testing that would fit what we are doing. And so the assessment and exhaustion, we also have immune senescence, but I think that's more of a anti-aging side of it. We also have added the telomere one. I don't know how. I mean, that's really more for the anti-aging crowd that we do see sometimes as well. Then we also have, of course, some panels that gives extra discount. I would say it's about a 20 to 30% discount on the individual test when they are put in one of these panels. And of course, we're always, if anyone have any ideas or any, what other testing we should look in for, we always value input on that side of it too, from both patients and from practitioners. So the long haul COVID with Epstein-Barr, HSV, and the Varicella zoster and immune assessment is $870. So it's not a cheap one, but I think if you're battling some of that, that could be a good investment to find out if you're actually having an active infection of these diseases. So any further questions on anything? Any discussions on anything?
Yeah, we have a question in the chat on cost if Medicare covers any of this.
Very good question. So we are currently, Medicare doesn't cover it, but we are working on that. And we are also working on other insurance. So we'll see how that goes once we get down the road with it. But Medicare is the first one, and we are in the process of getting that. Of course, like anything government, it takes time. But that's one of the first things we wanted to make sure that we get covered is for Medicare, and that kind of opens up then after that other insurances more or less too. So, great question. Yeah, that's part of part of our thing. Oh yeah, there I see the chat. Yeah, okay, good one. Yes, doctors, we need, it's like he was with hygienics. We need the doctor to sign off on it. Yep, down here. So you have to have a physician order it. So depending on the state, we have other, nurse practitioners can order it, chiropractors, and then depending on the state, some naturopathic providers as well.
So if we weren't seeing a doctor that currently did ILabs tests, would you have a list of area doctors or?
I don't think we have a list per se. Anyone that wanted to, I mean, we're open to anyone, so it's not hard for them to open an account. It's not a charge for them or anything. We just want to get their MPI number, etc., and get them in the list so we know they're actually a legit person ordering it. So, and I don't know. So that's a good question though too, because I know like at Igenics, we worked with a couple of those, I don't know what you call them, consolidators maybe for labs. And the name escapes me now for the biggest one, but that's something I should look into, because then that was a way, I think some of these providers had if people had problems finding a doctor, they had options for virtual doctors that they could use as well.
Yeah. And then I know a lot of people go up to that, I don't know if it's Plymouth or it's up 169 called like Anytime Real Lab or
Oh yeah, yep.
Lab or something. A
Yep.
lot of people went there for hygienic draws if your doctor wouldn't do it.
Yep.
Is it
And that's kind of the
similar
same
to
for
ILabs?
That's pretty much the same for ours too. Yeah. And we are glad you said that, because we are, where's my so we are looking at for patients where to get a blood draw. So we're building this out so you can find a phlebotomist close to you if your provider doesn't do it. So we want to make it as easy as possible for people to do it. And what's good with us, since we're local, is also our turnaround time is a lot shorter than Igenics would be. So, and that's with the T cells, it's important they need to reach the lab within 48 hours to be viable. But we do overnight with FedEx. So that's not really a huge issue for us here. It used to be with Igenics at times, and then we run these tests. It shouldn't take more than 5 days. I think we say 5 to 7 days, but it's a lot of times shorter. So, and then we want to, I guess I can. Oh, was there something else I was going to show? I did that one. Did I show? Oh, okay. So yeah, here's we have a few of these, and I don't know if they're out there yet, talking about the difference of the T cell. And I can share this. I can send this with to Britt, and she can send it out to you guys too if people want to see these specific things. So actually, I'll do that with the pricing as well, or the test rec, so you guys have it. So that's about it for me. If no one else have any questions, like I said, I'm not like Dr. Bruscano when it comes to having the knowledge of him. So, oh, okay. So draw most, yep, very, Dr. Rakota, very nice. They have to be done Monday through, well, since we overnight it, so Monday through Thursday, basically. Yep. So one extra day from Igenics, I think, was always Monday through Wednesday. Very good question there. I think that's, let me see here. And we're back to ILabs. And our InfectoLab is still active, the website. And there are some videos there specific for InfectoLab if people have other questions and want to read up on stuff. So, but I think that's it for me. I'm going to stop sharing. Now we're back to the main one. Should I pass the ball back to Britt? See if I can do it. I can stop recording. Oh, do you guys want to continue? Should I stop recording, or what do you want me to do?
I think we're fine either way.
Okay. Can keep going. Let me see. How do I pass it over to you?
I think
Is it
in the
on
upper right
top?
corner of my square.
There we go. Make host. There you go.
All right.
You got it?
I think so.
Correct.
Yeah.
Good. Well, yeah, thank you very much for taking time. And any questions coming up, please email me. I should should I send out an email, or does everyone have my email address? Right? Do you want me to send it through you? I didn't put up a screen. I could have. It's my jgamelius@ilabs.com.
Okay.
Or actually, i-labs.us. That's the easiest
I think
one.
yeah.
I can put
You
it in the
can
chat.
ask Ann or I or Judy down in Kansas City and we can get it. Yeah, it's jgamelius@i-labs.us is what I have. Yeah.
Yep,
Okay.
there we go. I sent it out right there.
Great.
So
So what is the for tick testing or for tick-borne illness testing? Like
yes,
what is the how sensitive are these tests or what's the accuracy or how do you measure any of that?
it's hard to do because of the T cells and the availability of the testing. It's hard to design um, a trial for specific. I mean, you kind of have to. How should I put it? It's because of the viability and be able to test the same blood for the same patient at that specific time, because we only have 48 hours to do it. We cannot measure this test against a sample bank because those are not valid tests, right? So that's the issue with getting a specific number on it, like we would do like at IGenics, where we would have a roster of old patients that we have their blood, and the blood is frozen and we can keep doing stuff on it. We can't do that with our samples that we have. So we would have to have known it's highly, so that's why I don't have a specific number on it. It's what I'm trying to say. They're highly specific. The problem is probably the sensitivity sometimes could be a little bit lower, but a positive is a strong positive. So, and that's a good thing. When I should ask Felix if he has any specific number studies. I know people want that. And that's kind of how it's been explained to me, that it's hard to design those validation studies for this type of testing.
And like I mean I'm a patient, I'm a sick person, like
Yes,
I trust my doctor to decide what to do and what tests
right.
to do, and then I try to pay for it. But like,
Yep.
what would be like, if I was a doctor, like what would be the pros of using ILabs testing?
So I kind of look at it more as a supplement to, I mean, like IGenics is great because we know they look at they look for more and find more. They're just very accurate. But we're looking at B cells, the IgGs and IgMs. We don't know in that specific infection. We can't measure how you are doing now. That's kind of the benefit with the T cells are that especially if you know you've done an IGenics test, you know this, I wouldn't spend any more money on new testing with IGenics unless you have other things you're looking for that you think you might have been exposed to. So then as you are treating it, it would be, the way I look at it, that would be better to use our testing to see, okay, what stage am I? How we do it? I'm feeling better. I'm doing much better. And now I'm kind of get a flare up, or I'm feeling, what are we dealing with? Is there a specific treatment, or is it Bartonella, Babesia? What specific ones are we dealing with this time? If you've had exposure to all of them, and then you can pinpoint your treatment better.
Okay.
That's kind of how I would
So
do
it's
it.
more like a monitoring
I would
system.
say it's a more monitoring and ongoing. And then also with the immune exhaust, you can see how hard is that if patients want to know that. I know it's hard. Like I'm feeling you sometimes, at least I hear this, people want to have like more of a proof and how am I doing? That's where this test kind of comes in a little bit. Like, yes, it is okay. I am doing better. I shouldn't worry about it. It's been as much. The immune system is working. If it's not, then we know that maybe we have to find some ways of improving that. But we all know how hard that is. But at least we have some indications. Or are we treating something that I'm not really dealing with at this point? Right? Because that's kind of where we can tell, yeah, no, it's not an active, it's not, you're not looking at like the COVID panel. Is it long haul COVID? Have I had a active COVID? Do I have COVID, remnants that would be activated within my body? This test would tell you that. So
Okay.
that's it's more of a monitoring, ongoing thing. Um, the cost is generally not as you were seeing, as high as some of the IGenics testing is either. And I'm hoping as we can get insurance to pay for some of this long term. But yeah, that's kind of what I like. I mean, it's one of those things. I mean, Dr. Verkota was on here too, but which she has a wealth of this understanding of all of this stuff. But I would say, I ask providers always asking me if there's some. Can I tell? How am my patient doing? Is there a test for this? And I think this is as close to that as we have, because it's very real term, as with the T cells versus looking at the B cells. So that's
Okay.
kind of, that's where I'm excited. And I think it's more one of the things over time. And I also see more, maybe, I mean, it is hard for the Lyme patients too, because we know but many of these other diseases are, we can treat them better than we can the Lyme disease, right? So I think the application is not necessarily always for tick-borne diseases for this, but it could be for some of the other side of it too, just to kind of see where we at, or we'll see what we go with the mold side of it. If we can find, that would be really interesting to me too, to see.
So what stage of the process are you for doing
We
that?
well, we do have the Asper, but I need to gain more understanding of the mold side, because I never really sold that side of it. And it's not black mold at this. I mean, it's just one of them.
Aspergillus, I think is what it's.
Yeah,
Yeah.
yeah. So that's where and we got to see if we can do other ways of measuring that as well. It's looking at antigens, and maybe urine test is better than the blood test too. I don't know how much it enters the bloodstream, but I think some of that stuff would be very interesting, and be able to expand on and give more. It's about giving more insights what's going on. So.
Well, I think a lot of us that aren't healing from our long-term chronic tick-borne
Yes.
illness are realizing that mold is often a part of the puzzle that we didn't know until we realized it.
Yeah, and it's also so hard to mitigate and take care of too, right?
Yeah, yeah.
I mean,
Like
we're
even
all
in the 15 years I saw Verkota, Dr. Verkota probably once every year and a half would say, "Are you sure you don't have mold? Because I just
yeah,
feel like," and I said, "No, no, 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 no."
yep,
And then, fast forward to COVID when I'm cleaning out a closet and I move a box and there's a spot that big on the ceiling that's toxic black Stachybotrys mold, and
uh,
but
yep,
I said no because I didn't know I had it.
yeah, and that's why I mean, if we can measure some of that would help too. I mean, how do you have? And I don't know how much. That's where I got to learn more of the mold side of it too. But I think
Yeah.
it's as I've worked with providers over the years, I see. I mean, it's always been something that's come up, but I think it's become more and more a topic that people talk about. So. But then, I mean, it's not, in the perfect world, people, oh, you got to move, I mean, we can't do that, right? I mean, it's hard for people to be able to just move. It takes
Well-
time. You get, you know, I mean, some of us have to, but yes. Are there other ways that we can mitigate or help or at least find out what we're dealing with, right? So that's the hope, just finding more insights. And that's what I mean. I love this whole just trying to help people get better. It's such a area where we need more of it, and finding providers to treat it. I mean, that's, you know, that's I'm trying to find more and more providers that will look at, you know, Lyme disease or tick-borne diseases, as well as just integrated functional doctors. I think it's great to have that and be able to build those that are around us here. And you know, that's, and also, I mean, that's probably where, I mean, we should try to find if new ones are coming in. I mean, it's such a hard thing though to, you know, people, oh, what's the best one? I'm like, that's, I can't really, you know, best one isn't, it's such an individual thing, right? So
The best one, what?
for doctors, I mean, who
Oh.
treats it, you know, and then also people are dealing with wait times for all of this stuff. We just need more providers that are educated and can help people. So.
Yeah.
So thank you for taking time for my rambling stuff here, but hopefully it helps some. And like I said, I'm always available for any questions. Just send me an email or text me too. You can share my phone number too. That's fine. So
Okay.
great. Thank you guys, and hopefully I'll be back.
you.
And then yeah, you can. I mean, it's a good thing too to ask. I know Dr. Otten is coming up to talk, right? One of these
November.
times.
Yep, I
Yep.
think.
So
Yep.
I mean, he knows our testing well. He's used it. Then other providers, I know you said Dr. Thatcher is coming from the Tick-Borne Disease Center of Excellence too, right?
Yeah, probably either January or March.
Okay.
He decided to speak in the winter.
Yeah, no, makes sense because they have way less of patients to deal with, I think, in the winter than they do otherwise.
Yeah.
But you know, any of these, it's great to.
So both of them both use ILabs?
Actually, Dr. Thatcher doesn't use it yet. I haven't had a chance to
Okay.
see him, but I mean, he's very knowledgeable as well about all the, you know, IGeneX testing and all the other stuff. And I think he's working on, I think he's part of like one of the new tests that are coming out too and helping them. So I'm sure he'll talk about some of that. But he's
Well, and
good too.
Judy's still on here. You said a couple weeks ago that you were down in Kansas City. So do you have some doctors?
Yeah, so actually I was and I probably can share that. I was in Kansas City and the ATMA clinic, Dr. Connor Kieski. He's actually Albert Lee native, so from Minnesota, I found out. But they are just starting to use our testing. And I think it's Dr. Is it Dreyer too down there at Premier Integrative are using us too. There was a couple of other ones too that I met with that I couldn't see when I was down that way. And then I think we had one of the providers down there passed away, I think last year too, unfortunately. But it sounded like the family is continuing his practice. And his name escapes me too, but maybe Judy can help us.
Hi there. I've had internet issues. I'm
Oh,
sorry
okay.
about that. I don't, those two clinics don't even ring a
Okay.
bell here.
Oh, interesting. Okay.
You said Premier Integrated?
Yep, and Atma. So Atma used to be Jessica Yellison.
Oh,
Her
okay.
clinic.
Yeah.
So when she moved, right?
Yes, we don't have many people that see her.
Okay.
But you're saying, but Dr. And what was his name?
Connor Kieski.
Oh,
Keyeski.
okay.
So at my clinic.
Okay. And
I think
they
they're
are,
looking at new patients there for sure.
okay. Okay. And then you said Dr. Dry something?
Dreyer, I think Premier Integrated.
Have not heard of it at all.
Okay, so they are just on the north side of town of Kansas City. Let me
Okay.
see here. Actually I'll pull it up because I think I have it. No. Let's see. It's my Premiere.
Okay, I'm gonna quit the recording. I just realized I was
sure.
still recording.
Okay. So you